Smatana is the director of the Health Policy Institute in Slovakia, which is the analytical and former advisory department of the Ministry of Health of the Slovak Republic, which centralizes and processes various data about healthcare systems in the Slovak Republic. Hi, Martin. Good to have you on.
Hi.
Welcome. I'll start right off with the first question. Martin, how do you process and evaluate healthcare data? It's a tough question, though.
Well, yes, it is also a very general question. And actually, I would start probably with, or in relation to the COVID situation, because I would say that Corona and COVID showed us the way how the data needs to be collected, evaluated, and processed. Because even though, for example, in our case, in Slovakia, I think we are one of the best EU countries in terms of a number of COVID positive patients, as well as number of deaths per 100,000 population. It was not because of the way how we process or collect the data. But when you look into countries which really were at, well, great risk of actually getting infected, for example, Taiwan, which is only, I think, 80 miles from coastline China, they managed the situation very well without actually having to shut down most of the shops and services and the industry. And they did it because of the way how they collected and processed data, and also they did it because of the way how the outcomes of the data were respected by authorities. And the way how this should be done, and the way how it needs to be actually done, is that all data needs to be collected and processed centrally, which means that the COVID and the Corona and everything actually showed us that if we give up some of the privacy issues we have, if we give up some of the power silos we have over the information, the results are not only that we can save the lives, but we can actually save billions of euros, because of we can react quickly, we can be more precise, and actually we can do or make decisions based on the facts and not politics or opinions of some leaders. And the Taiwan and Singapore and the countries around that area are a very good example as how it can be done. And I believe that us as Europeans will learn from these examples.
Right. So you mentioned a very good point there, and actually we have a question in the chat referring to it. In this situation, and in the case of a pandemic, how do you ensure you maintain privacy of this care data? You said it's a sort of balance of course, the results for the entire system, but maybe I'll let you elaborate.
Well, yes, the privacy has always been a concern, and it always will be a concern. But if you, for example, look into, once again, the Taiwan case, they have at the central level a variety of different IT systems which had the data, right? But every single of the system had the same unique ID for every single inhabitant, and all they needed to do was to get an approval. They can combine the databases into one. For example, what they did, they've combined not only the information from the healthcare database, they've combined it with customs, they've combined it with the information from airline companies, from a variety of sources, so that they could triage patients which were coming from other countries without actually having to send everybody into the compulsory state quarantine, for example. Then they've combined pieces of information from the healthcare data and some social information, so they can actually retrospectively check if there was somebody who would look suspicious in terms of having symptoms of COVID. And if there was somebody, they would send him a message, please come to get tested. So the privacy concerns are always there. In the case of, for example, Taiwan, it was a unique situation, and in this unique situation, only for this purpose, they've combined the databases. But what we need to have is actually the ability to do that. For example, in our case, we have the same ID for healthcare data and social data, because it is done by the same provider. But when it comes to every other pieces of information from other ministries or from tax office, we have like different ID, so we can't combine it. Right? We can combine only one pieces. And I think this is critical. I mean, we need to have systems which can be integrated, but only if needed, only if there is an emergency state. And I think this situation, that only if it is an emergency state, provides at least some layer of safety and security over the data.
Right. Thanks for that. What steps would you recommend to take for a system in order to get there? You're talking about this full centralized composition of data. Where do you start?
Well, it's a good question. First of all, and this is something that we have not done since 2015 in Slovakia, we need to do a proper stakeholder mapping, because what we've found out that we would collect and thousands of pieces of information of the data that actually we don't need or don't actually even use, but there is always somebody who either have to report it or check it or something. So first of all, once you do a proper stakeholder analysis and you check all the outputs that you need, then all you need to actually is to find out how you can integrate with existing providers. I mean, if it is actually possible to integrate it, if you need to build a system about the existing system, or all you need is actually to do some integration and it is all in one piece. But it all begins and starts with a proper stakeholder analysis, because you will at the end find out that you don't need to integrate every single piece of information that there is in the system. Maybe all you need is just a few lines, few sources, in order to be able to govern a country as it should be, in terms of you have a data which you process into information, and then out of that you have a suggested solution.
Great, you're absolutely right. We have another question from the chat. Actually, it refers to peer-to-peer tracing systems. It's an idea that we talked a lot about at our last virtual conference. Mr. Preet Tover from Estonia told us about it. And so he's asking, what is your opinion on peer-to-peer stealth tracing systems?
Sorry, I didn't catch the last sentence.
What is your opinion on these peer-to-peer tracing systems?
Right. From my perspective, this system enabled, for example, in Singapore or South Korea, I think that they use them. Also, they had in Czech Republic. It enabled to ease the measures much earlier or much sooner than in other countries. For example, if we had it, unfortunately, we had to change legislation in Slovakia, and for whatever reason, it didn't pass through some whatever issues. If we had it, we could have opened the shops, schools, and everything maybe 3 or 4 weeks earlier than we did. And we've calculated that I think that every day that we had all shops and industry stopped, and because of the issues, I think we lost around 100 million euro on daily basis out of the income we could get. So if you calculate that all you needed was to actually to give up a bit of your privacy that anyway you would give out to Instagram or Facebook or whatever, you could save billions of euros over a couple of days. It is pretty obvious what my opinion is. I mean, I really supported this issue. Unfortunately, it didn't work in Slovakia, but I think that if the second wave comes, this is the only way how to prevent that. Once again, we will have to shut down all shops. This is the only way how we can make sure that the new measures that would have to come would be local based or regional based and not national based, right? And this is very important because this enables us to react quick and to be very precise. And I really hope that the legislation will eventually pass. And if the second wave comes, even Slovakia will have such system.
Martin, we hope so as well. We're definitely with you on this. If the second wave were to come, what else should we be doing to prepare for that, except for this topic that you just mentioned?
Well, I believe that most of the countries are already prepared well because we've learned from each other mistakes and best practices. I think that only one thing, or very few things that are not yet or spread in some countries is the smart quarantine, which we actually launched a couple of weeks ago. I think only very few countries use it. It's an application which also was used in Taiwan or Singapore and South Korea, which actually checks your location. You have to face check on a regular basis, and in that case, you don't have to go into state quarantine. And I know that not every country had a state quarantine, but we had it, and this is something that could spread because across other countries, because it proved to be very well, how to say, humane, I would say, and also it saved great deal of stress and mandates and everything. And this is something that could be adopted by other countries as well.
Thank you. I absolutely agree with you, and I think most of the people in our chat definitely agree as well. So we're talking about wave 2. What about future pandemics? Is there any way we should be transforming healthcare data and our systems in order to prepare for this, except for, of course, these regulations?
Right, this is a good question, because I don't think. Well, yes. Once again, I will use my favorite example: Singapore, Taiwan, South Korea, and I believe that not only the legislation, but not only the integration, but also the decision-making processes needs to change. For example, in many countries, and not only in Slovakia, but in Czech Republic and all other countries that we actually monitored on a regular basis, some countries had very good data and information, everything, and yet the decision-making processes were not made based on it, right? They were used only as some sort of a guide, even though those pieces of information were actually extremely correct, extremely right, precise, and everything. And what we need, for example, I would say, what we need is actually to make sure that once we have verified, precise information, it needs to be regarded as a fact that needs to be implemented, not as a guide, right? Because as of today, we've used information and modeling and analytics and everything as some sort of tool that would help us navigate in the throughout the situation. But I believe that the data needs to be not the guide, but needs to be the cornerstone of everything that we do, right? Because also in our case, we use the data, or the decision makers, our prime ministers and ministers, use the data only when they were unsure as to what to do. But considering that we have not had such situation in Europe since, I think, First World War in terms of pandemics, none of us had experience, which means that most of the decisions we made were based on, well, our opinion or what we believed happened in China or everything. And that's why I believe the data needs to be at the cornerstone, and then we can make decisions, not the other way around, that we make decision and then let's find data which would prove that my decision was correct.
Right, you're absolutely right. We do need to follow data, it's definitely. We have a lot of talks upcoming about data and how we can use data. Before we end off, Martin, do you have any other key takeaways or learning lessons in this era that we're currently in that you'd like to tell our viewers?
Well, yes, and once again, I'll repeat myself, and I believe that the key lesson that we learned when it came to data and analytics from COVID was that we need really to give up or we need to actually loosen the privacy concerns we have, because the benefits and the outcomes, if it is done well, are extreme. And this is something that we need to really push and persuade people, all of us, because if we don't do it, we are losing billions of euros, we are losing hundreds of years of quality lives lost. And all we need is just to do the same as we do with our Facebook or Instagram accounts. We just need to give up some of our information in exchange for unbelievably great outcomes and benefits. And this is my key lesson learned, and something that we need to really work on, that we need to persuade people that this is for greater good. And COVID showed it very well.
I absolutely agree. And that's what we're actually trying to do here. That's why we're so glad to have you on today, so we can do that and share the insight from a person with your expertise in this situation. So we talked a lot about data. How much of this situation is actually, you're speaking about the end users being more accepting to these privacy terms. Do governments really need to focus more on just relaxing their data privacy policies?
Well, not only, because in many cases, the problem is not with the end users, the problems are actually the governments. For example, if you look, I think, into Switzerland, and I think that they have a massive problem there, that each of the cantons, or whatever they call the regions, they have their own a data curator, which is responsible for sharing data. And as far as I know, they have a massive problem with actually sharing them at the top government level. So the issue is not always with the end user. Actually, in our case, the issue was not the end users; it was actually the government and the legislation we had and the people who govern the legislation. So, but I believe that considering that, as if you read the news, every other day you have some good practice, a good example from the countries who actually really shared and integrated data. And I believe that even the top decision makers in our countries and the countries around us will actually realize that they need to change the mindset they have. Because yes, even myself, when I was responsible for the data, it was always difficult to share, right? Because there's always can be a problem, etc., etc., etc. And in fact, we got into several small lawsuits because of the data we published. But the only way how to actually really exploit the data and get the most of it is that we will change our mindset. And that's why I'm also grateful that I could actually give a small speech here, because even some of our guests here today could be the decision makers who could change the mindset to somebody, and then all of us will benefit.
Right. Thank you very much, Martin. Do you have any other closing remarks before we end off? We just have 2 minutes left.
No, I think that was my key message that I wanted to.
Perfect. Actually, we'll see you in about 23 minutes in a conversation together with Kathy. Kathy will be joining us in just a minute. So once again, Martin, thank you so much for joining me today for this conversation. I'm excited to see you again on the stage in just a couple minutes.
Thank you as well.
Thank you. I'm back. And I'd just like to introduce our next session to you, which is the Digital Health Game Changers of 2020. And it's a great pleasure and a great honor to welcome with us today Ms. Kathy Farndon. Kathy has held a senior healthcare management role both in the UK, Canada, and New Zealand. Kathy has been head of data and information governance at NHS Digital and led the data and informatics elements nationally for the 100,000 Genome Project. She has change management strategy and process redesign for clinical environments using a quantitative health-specific approach and Lean Sigma methodology. Kathy has experience in both commercial and not-for-profit healthcare organizations. Her overarching aim is to make a significant contribution to increasing the effective use of technology to support clinical decision-making, thereby improving care. Kathy, hi, welcome.
Thank you.
It's very good to have you on. Do you have any opening remarks before I ask you the first question?
No, I'm happy to go straight ahead. I mean, I think this is a great conference, and I think the idea is that we can all learn from each other.
That's our idea as well. So Kathy, maybe from a more general perspective at this point, how has healthcare changed recently from your perspective?
Well, I think it has changed dramatically. IT has always been perceived in the past very much as boxes and wires, and hasn't really embraced that holistic idea of what digital technology can actually do for healthcare. I think a lot of that is because it is quite disruptive. It's quite disruptive, transformative change, and people have been very nervous about that. Particularly clinicians, if you want to digitize a form, they like the form that they've always used, and as long as that is up on the screen, they can use it. They don't necessarily think of all the other benefits that the digital technology can actually provide by digitizing the form, if that makes sense. But I think in relation to the pandemic, it has made even more change. I think it's been quite liberating, really, for digital technology, because clinical practice has had to change, the processes have had to change, and so they have been calling on digital technology in order to be able to support those changes. So I think it's been quite liberating. And I think we have to, though, be very cognizant of the fact that there are privacy concerns and there are safety elements that we have to be sure that we are taking care of. This is very sensitive data that people are providing. And so we have to be acutely aware of that. But I think the public are also much more accepting of digital technology now. I mean, let's face it, we can, I'm getting quite skilled now at being able to book time slots for my grocery deliveries during the pandemic. And yet, to book a hospital appointment, I have to ring up and wait for a letter to arrive. Why can't I do that online and look for a convenient slot? There's lots of areas, I think, that we can be looking at. But I think it's allowed staff to be much more flexible working. We're encouraging working at home. So that's going to be a tremendous advantage. It's also meant that we can look at our real estate as well and make sure that that is used to the best advantage. If we've got more people working at home, some of the back office functions working at home, can we use some of that real estate for additional clinical care? So it's been really, it is a change, a massive change.
Right. Thank you for that. And I completely agree with you. Where would you see the most important opportunities and challenges these days that arise maybe in your field or your vicinity?
Well, there are just zillions of areas where it can change. I think one of the examples that I've quoted quite a lot over the years is when I was living in New Zealand. I could buy presents for my family in the UK and I could track and trace those parcels right the way through to their doorstep. When I came back to the UK and set up the 100,000 Genome Project, we had challenges even tracking and tracing a single blood sample around a hospital from the ward through to the laboratory. So we can learn from other industries as well, I think. I think we've always considered health is very special, and there are elements of it, certainly in the clinical area where it is. But I think we can learn from other industries that have already cracked some of certainly the back office functions. But as far as clinical care is concerned, I mean, it's mind blowing the things that can happen now. We were talking. It was Holger was talking earlier about AI. I mean, that is a massive area, and certainly in the genomics area, in radiology and pathology, imaging. But I think we have to be really careful about the algorithms that are developed for those pieces of equipment. I think we need to make sure that we professionalize the actual development of the coding systems, because at the end of the day, the learning and the AI and the machine learning tools is only as good as the data that it's getting. And so we need to be able to authenticate the provenance of the data and where it's come from, and its accuracy.
Right. Thank you for that. We're talking a lot about disruptive technologies, AI, machine learning. And this brings to my mind, and Daniel in the chat mentioned this, how close are we to the paperless office? We're talking about such a contrast in technologies.
Oh, I think we're still quite away from that. I think a lot of the challenge is the fact that there are so many legacy systems still in existence, and there is a huge cost element to not only changing of the equipment, but of also migrating all the data that is in those systems. Because at the end of the day, in the past, a lot of the data has been formatted in those vendor-specific formats for that particular equipment, in a way to keep you captured with that particular vendor, although I don't think they'd probably admit to that. But I think there has to be, going forward, a move to open platforms, open standards. We need to be able to share data a lot more easily. And we can't do that at the moment. And so I think that is a big push that we have to have now for open standards and making sure that things aren't country specific. I know Martin was talking about that just now, about being, the Swiss and the cantons and having their own little versions of things. I think, I think the virus has shown us the virus doesn't have boundaries. It's a global pandemic. And so we need to be thinking much more internationally, globally, about how we store data, how we share data, and obviously with the privacy concerns uppermost in our minds as well.
Yeah, thank you for that, and I absolutely agree with you that it's a combined effort globally. Daniel also points out another question in the chat. He mentions, what if you say in 5 or 10 years from now, it became normal to download updates to your genome to cure genetic disease and 3D print them at home or in the surgery? What are your thoughts on that?
I'm sorry, I didn't quite catch all the question.
He says that, would you say that perhaps in 5 or 10 years from now, it became normal to download updates to your genome to cure genetic diseases and 3D print them at home or in the surgery?
Well, I can't imagine that anyone's going to have any. It would be brilliant if they could, but I can't imagine at the moment. When you talk about a single whole genome sequence, that's without any clinical data linked to it, a whole genome sequence on an individual person is about 100 gigabytes of data, which is the equivalent of 20 plus high definition films. That's humongous data. And a whole genome sequence on its own means very little, because everybody has variants to their genome. So you need to be able to link that with other data, with wearables, with other health data, clinical data, phenotypic data, laboratory data, all sorts of other data. So we are talking masses amount of data. It's a pipe dream, but it's a lovely vision to have.
It definitely is. And when we're talking about visions, we have a lot going on right now. Do you have any thoughts on what's to come? And where are we heading with digitization?
I think this pandemic has given it a real kickstart. I'm really excited by it. I think this has actually opened the door for people to see that there are tremendous advantages to actually the services that can be supported by digitization. And I think we have to think of it that way around. I think in the past, we've always thought about IT and digital technology as a product. And we've tried to shoehorn clinical processes into using those products. Whereas now, I think this pandemic has actually shown us that the opposite is true. We need to make sure that the clinical possibilities are people's imagination, and then we have to come up with developing technology to support actually the benefits that can be had from that, and improving patient outcomes and actually getting some answers to some of these really challenging questions.
You're absolutely right. Actually, this is about a topic I spoke with Martin just recently. It's the contact tracing and the secure information regarding that. There's a question with that a lot of countries are doing their own applications and they're not compatible with one another. Do you perhaps see any EU regulation on the outlook to maybe monitor that and make that more possible or promote that?
I think there's lots of opportunities for contact tracing using devices. However, it has certainly become evident in the UK that people much prefer the human contact with regard to being told to actually shield or self-isolate. You know, that they are quite challenging things to do. Would you really want to get a text to say, sorry, Thomas, you've got to stay indoors for 14 days? You know, I could imagine what you'd do, your reaction to that. It probably wouldn't be terribly favourable. There are elements, I think, where there needs to be that human contact, where there are perhaps conversations that need to be had, because you don't necessarily understand the person's situation, whole situation. The contact tracing information is very basic, and it's only what people are putting into it. So again, it's the verification of that data as well that is very challenging. And also, of course, we've highlighted the fact that if it's using things like Bluetooth, for instance, people that are living in high-rise blocks of flats, it's absolutely useless, because you could be living next door and Bluetooth will go through those plasterboard walls without any problem at all. So you might not actually be close to that person, but according to the tracing app, you would be. You'd be sitting there for hours probably with that person. So, you know, I think there are lots of limitations to it. I'd like to see that testing, testing is paramount to the success of any contact tracing. But I think ultimately it will be a combination of an app that helps with it, and also there will still have to be some sort of personal contact as well.
Right, thank you for that. Do you have any final takeaways or remarks you'd like to leave with our audience before we move on to our next conversation with Martin together?
Oh, I mean, it's been a wonderful privilege to actually have this opportunity to speak. And if anyone wants to have any further conversations, I'm more than happy to make myself available for them.
Great, thank you. Actually, I'll just move Martin into this room, and we can proceed with the next conversation because you're both involved in it. Welcome back, Martin.
Hi.
Hello, Martin.
So this panel discussion is focused on the adoption of personalized healthcare, the comparison of adoption of personalized healthcare between the UK, Slovakia, and maybe other countries and regions. Do you have any opening remarks before I get down to the questions?
Are you talking to me or to Martin?
Either are great. Martin or Kathy? Yeah.
Martin, you go first.
Well, I would probably have one, which is that I really believe that the whole concept of genetics and genomics will one day, I think within 5 to 10 years, cause one of the biggest rifts in our healthcare systems. Because as I talked about a couple of minutes ago about the privacy and safety issues and everything, I believe that there always will be some part of our population that will refuse to have their genome sequenced and diagnosed, even though they could get better, more precise, cheaper care. And I think that this will cause a split, and some part of the population will get better care, and some will get worse and even more expensive care. And I think this will end up with a dual system, with some actually being healthier, paying less than the rest. And even though it sounds very stupid, I'm absolutely confident that this will happen, because there will always be some group of us that will refuse to have this piece of information shared, even though you could get better care, cheaper, and live longer.
I think it's quite different from the UK perspective in that we have a public healthcare system. And our perception of personalised healthcare is that it's going to be much more relevant. You take cancer care, it's looking for the treatment that is the most efficacious treatment for you, depending on your genetic makeup. And I think we've got to get out of this idea of one size fits all. You've got a headache, take an aspirin. It doesn't work for everybody. You know, you might react to aspirin, someone else might react to paracetamol, ibuprofen, whatever. It's very much how you metabolize these treatments as well. So I think I mean, there's a tremendous cost saving that can be made by making sure that the treatments are going to be the right treatment for the patient, because it's going to also have the best outcomes for the patient. So it's going to be much better all round. And I think that's the drive, certainly as far as the UK is concerned, on personalised medicine. It's making sure that the outcomes are the best outcomes for that individual patient. So I don't think it's necessarily going to split it in the same way as you're perceiving it, Martin, for your country.
I completely agree. And but what happened to in our case, because that we are really behind the UK and other countries, maybe 10 or 15 years, because we didn't have any proper genomics plan or strategy. We still don't have one, but we tried to prepare one. We started last year, and we had like plenty of roundtable discussions and debates, including the ethical topics and a variety of related issues. And really, for whatever issues, probably because we are a mostly very religiously based conservative country, plenty of people refused to have their genome tested or to have it diagnosed, etc. Even though we try to explain the added value and everything they have, for whatever reason, they feel like it's how to say invasive to everything they have, and they want to have a proper chance to, you know, to get the treatment as they require. Because if you have them tested, they get the most efficient and effective treatment, right? It is not always what they want to get. And this was the problem we've had with them, which means that we have a long way to go in order to actually, well,
yes, certainly. I mean, I think the benefits certainly outweigh the risks, but I think you're absolutely right. There are huge ethical issues around it, and we've had to work really hard on that. With the 100,000 Genome Project, it took us absolutely ages to get the ethics for that project signed off, because it was a hybrid project. It wasn't just research, it was also for clinical care as well. And it raises lots and lots of questions, and it's such a new area as well. And a lot of the time, we don't even know the questions we should be asking, do we? It's groundbreaking, but that makes it more exciting too.
Right. Thank you, both of you. We have one question coming from the chat right now from Gunther. He says, do you believe that we will have global providers for personalized healthcare that will offer their services for self-paid clients? Do you have any thoughts on that idea?
Sorry, you were breaking up, Thomas. I didn't quite catch that question.
Oh, let me repeat that. We have a gentleman in the chat asking, do you by any chance believe that we will have global providers for personalized healthcare that will offer their services for self-paid clients? That's not on the lookout.
I'm not sure that I can answer that one. Martin, do you want to come in on that?
Well, I'm just trying to imagine how that would work.
Yeah, I can't think.
That would mean that it would have to be a private service doing the sequencing and then the treatment, which would be extremely expensive, probably, and inefficient.
Yeah, I certainly can't visualize that for the UK.
Well, we'll have to think about it, for sure.
We will think about it. We will come back to that person with an answer.
All right, thank you. Then we'll move on with the next question. Hold on for just 1 second. Kathy, this is a question to you. So genomics data is adopted in the healthcare system. What would you say the UK did so well to get their data integrated?
Oh gosh, it was incredibly challenging to get all that clinical phenotypic data in order to be able to run the project. And there was a huge amount of development work that needed to be done by the 85 trusts that were involved, trust hospitals that were involved in the project, in order to be able to extract the relevant data. But there was a huge amount of work done on using international data standards. That was really critical to make sure that we were comparing apples and apples. We had to, and it was really important that it wasn't just a UK data standard. It had to be international, because there might only be a couple of people in the UK with that particular rare disease. But there may be lots of evidence in other countries in the world. And so we needed to use international data standards so that we can make sure that we were able to translate that information and use that information and draw it from all over the world. So it was a drive for those data standards. It was a drive to get interoperability, and not just physical interoperability, but semantic interoperability as well. It was a challenge with the laboratory systems to make sure that, again, the coding for the sample data and metadata was all standardized. It was using the research terminologies as well, so that analysis could be done, or the bioinformatics and the analytics that need to go on. So there was a lot of development work that had to be done. And it took a while, but everyone was so dedicated that we've set ourselves up really well to move forward into personalized medicine.
Martin, do you have any thoughts on that, or perhaps comparing the outcome to Slovakia?
No, I think Kathy summarized it very well. I mean, in our case, as I mentioned, that we are at the very beginning of the entire process, and actually we really studied the genome project in the UK and a couple of other ones. So I mean, yes, that I completely agree. Yeah.
Mm.
So you said we're in the beginnings. Could you maybe elaborate on where exactly, or sort of where you think we are, and where are we going with that?
Right. I thought I meant that in Slovakia we are at the very beginnings of the entire project or strategy, because if you want to have a proper personalized medicine, you need to have some, let's say, some prerequisites, some foundations, or cornerstones. So you need to have a functional system of sequencing and testing with precisely set attributes as to who you need to test, what sequence you need to test, and everything. We don't have this. It was randomly created based on demand, based on somebody read something on the BBC or whatever news, and they wanted to have it done in Slovakia. So it was a very organic process without a clear strategy or a vision. You need to have a biobank where you can store the samples. We don't have a centralized biobank. We have one or two or three small ones, but we don't have one centralized with clearly predefined samples that needs to be collected. We do not have a payment or pricing mechanism for this. This was also created as you go, which means that when we, for example, looked into how much you pay for BRCA testing, we pay like double compared to Czech Republic, for example. Which means that we are, and what's most important, we do not have vision as to where we want to take it. I mean, what is the outcome of this? Do you want, or the KPIs they want to achieve? Which means that we've prepared a first draft of a concept material which governs all of these issues, and hopefully after the COVID is gone, this will become a one of the strategic materials for the years to come. And the worst thing is even though we've tried to copy paste every single best practice we found, not only in the UK, but in Estonia and their projects, they have other countries. Croatia, for example, last year established a nice project, I think, with Roche, the company. So we looked into every single of the projects available ones, but it will take years to collect the data samples, to analyze it, and to make it a part of the regular processes, which is very sad to acknowledge, but it will take us, well, I don't know, Kathy, you can say 5 years, 10 years to catch up to something which is already standard in the UK or some other country. So,
I think we had the advantage too that we focused initially on rare diseases and cancers, specific cancers, where we were sequencing not only the person but the tumor as well. But that came with challenges because in order to be able to do a whole genome sequence on a tumor sample, you need very specific quality and quantity of DNA to be able to do that. And so there were a lot of issues around that. So cancer was actually a lot slower to kick off than the rare diseases. But by focusing on rare diseases, that actually got us going. And to be able to give people a diagnosis and I mean, that was just a tremendous advantage, and we did that very successfully. We came up with lots and lots of new rare diseases that were highlighted, and so if people can give something a name, it's much better to create a plan in how to deal with it. But I think it also highlighted the fact that not whole genome sequencing was what we were doing in the 100,000 Genome Project, but you don't need to do whole genome sequencing for everybody. Most of the cardiac congenital conditions are genetic in origin, and they will be found in, I mean, if you had a panel of about 176 genes, you can generally identify most of those cardiac abnormalities. And so there are cases for long panels as well. So it's really, I think you've got quite a challenge ahead of you. It will be a journey, but yes, learn from other people, very much so.
Great, thank you. We have one remark from Yara, one of our other speakers, I mentioned before. It was regarding the question of contact tracing. She simply mentioned that in regards to the European regulation, the EU just released a proposal for interoperability protocol for contact tracing apps regardless of their architecture. What are your thoughts on that, Martin, perhaps?
If I'm not mistaken, this regulation would enable to exchange data between systems in different countries, right? However, it doesn't deal with the issue that, for example, in our case, we have our own set of regulations which actually forbid to use such peer-to-peer tool, generally speaking. So, well, if the regulation it will be passes on and it will be in effect, the IT architecture will probably accommodate to it. However, we won't be able to use it still, so it won't probably change the issue or won't solve the issue we have in Slovakia, unfortunately. And not only in Slovakia, as far as I know, we had the same issue. Some of the countries had the same issues with their own legislations and courts, etc., etc.
I think it's also quite difficult to. I mean, you were talking about a two-tier system with the genomics, but I think with contact tracing as well, that it's relying on people having smartphones, and not everybody does have smartphones.
Right, thank you very much for that. There was one question previously for Kathy. It's from John, another of our speakers. He mentioned, or he asks, how can we encourage the doctors and nurses in the clinic to better demonstrate their needs, and perhaps maybe in Slovakia as well?
I'm sorry, you broke up again, Thomas?
I'm sorry, I'm breaking up. I need to check this afterwards. I'll speak a bit closer. John asks, how can we encourage the doctors and nurses in clinics to better demonstrate their needs?
Their needs for digital technology.
Right, and for changes.
Well, I think it's a case of actually collaborating with the people in the hospitals that are looking after IT, highlighting their pain points, because everybody has irritating pain points. You know, in my clinical days, the fact that you had to log on to different systems 5 or 6 times, why can't we have a single log on? You know, but you do it because it's part of your everyday. It irritates you, but you don't necessarily think to speak about it. So I think there needs to be a lot more collaboration, and identifying of those pain points and saying, actually, guys, can you help us with this? And so I think in future there will be a lot more multidiscipline meetings going on. I would like to think that that would be the way forward, that there can be help provided. But I think a lot of it in the past is that IT individuals have been lurking like little moles in the basement of hospitals, and they surface occasionally when there's an issue that they have to solve. Now I think there has to be a much more visible presence. And I think we need to make sure that the IT people have professional career paths as well, and upskilling in the digital technologies as well. And we need to make sure that the staff are trained well in the technologies that are provided for them. I think digital literacy is something that is going to become quite a hot potato in the very near future.
Right, thank you. Martin, do you have any thoughts on this? Because digital literacy is, of course, an issue in Slovakia as well.
Well, once again, I think that Kathy summarized it. I'm well. I mean, that's it. I mean,
great. You're absolutely right. All right. In this case, do you have any closing remarks before we finish this session, and then we'll be moving into the startup presentations?
Martin, you go first, because I stole your thunder on the last question.
No, thank you. So probably my last remark would be that I would probably call that other countries, other peoples, other governments don't make the same mistakes that we did. I mean, we really didn't pay sufficient attention to this the area of personalized medicine, and it. As of today, the public debate, when every time that topic comes to a personalized medicine, is only about expensive medicines. It's only about how it's going to cost us hundreds of millions euros, and we lost any chance of actually getting back to a rational debate that actually it will save expenses, it will improve our life expectancy and quality of lives. And that will probably be my last remark, that do not make the same mistakes. You need to get into it, prepare the strategy, communicate to people. Otherwise, you will be at the same spot as we are today, because we are just trying to put up some fires. And hopefully one day we will catch up to the countries such as the UK or Estonia, and even Croatia is actually marching at very good pace forward. So that probably would be my last thing to say.
Thank you, Martin. Kathy?
Yeah, and I think it's true of both personalized medicine and digitization as well. I think we need to have a vision of where we're going. And then we can plan the route on how we get there. But I think we need to be able to articulate that vision of what we want to do. And there might be lots of, I mean, I use the example of roadways. And, you know, if you know that you want to go, if I want to go from where I live into London, London is my end vision, but there's many, many routes I can take to get there. And so and diversions as well when you hit obstacles. And I think we have to be open to that way of thinking rather than being too rigid.
Great. Thank you very much to both of you. If we were on stage, I would ask for a nice audience clap at this point. But thank
We'll
you.
take a virtual one.
Okay, we'll do that. Thank you for joining me again today, and I wish you a great day.
Thank you.
Thank you.
Thanks for the privilege.
Thank you. All right, ladies and gentlemen, thank you for that inspiring talk once again. And we'll just be moving in 2 or 3 minutes into our startup presentations. So please hold on and keep watching.